points are absolutely valid. Some of them probably are not going to be applicable in the field, especially when we talk about ECPR and that sort of thing, and our intra-arterial blood pressure monitoring. But here's where the down and dirty is. When we take care of children, we have to have something to go to. Whether it's an app on a phone like Hantebi, or it's things like letters. We want to make it simple. When I teach this all the time to EMS as well as physicians and nurses, the one thing I want to do is be able to walk away from that, knowing that there's something that we can jump from to assess children. And it shouldn't be complicated because we're already in a whirl of activity when a kid goes down. Nothing's more stressful than when a child needs to be resuscitated. So I always make it easy as alphabet soup. 90% of the kids that we take care of have a pulse. So our alphabet is really going to be of use here. What's the airway? Is it patent? Is it able to be maintained? What's the breathing status? Work of breathing? What's the rate, fast or slow? C, cardiac. What's the kid look like from core to periphery? What do the pulses feel like from up to down? What's my manual blood pressure? It's what I love about teaching EMS here and also at Lord Fairfax is because you all know what a manual blood pressure gives us and how important it is. I still struggle with anybody that are nurses or in a hospital understand that you have to touch the kids to get a lot of information. So getting that manual blood pressure, especially when they don't look right or they're not right, is of value to you. Because you have to see the quality and feel the quality of the pulse. You get to feel the temperature of the skin. You can know if it's cap refill. You also can hear the sounds. And that, in essence, if it's soft, to me, in my experience, that's probably not going to be as impressive. In other words, they don't have a lot to support it. D is your disability or neuro assessment. Other letters we use for that is what we use in the field, APCU. Are they alerts naturally? Are they alert only to verbal? Are they alert only to pain? Are they unresponsive? So APCU is another set of your alphabet soup. But let me just make this really importantly clear and abundantly clear, and I know you all know this. The disability or the neurostatus of an infant or child will change exactly the way they improve or deteriorate. So if they are getting worse, what's their neurostatus going to do? It's going to go in the tank. So, and everybody gets nervous, especially those in the hospital. Well, how do I do a neuro on a kid or an infant? It's really quite simple. What do we listen for? The cry. No infant should like you unless they're your own, okay? And even that's questionable for most days for me. But that being said, infants cry. The vigorous movement is very important in my assessment of this child. And for kids, if they're verbal, that makes it even a lot better. And they also are averse to pain. So whether they're infants or children, when we get them and they are in the back of the unit, they're probably not going to be back there to have a good time. So anything that we have to do like IVs or even putting them on O2 should really upset them. So I'm looking at the response to any noxious stim. Disability is your best friend in looking at your neuro assessment for your kids and infants. Trust me on this. And what person could be of help to you, especially if the child's an infant? Please, one caregiver, the best one, is going to be your best resource because they know this kid and how they're acting. And the worst words I do not want to hear when I assess a child, either in the field or in the ER, is, yeah, they're not acting right. That's all I got. It's a red flag. So that means neurologically, that caregiver picked up some nuance that changed in their baby. And then E is exposed. It's not that I want to get them all naked, especially if it's cold outside, but I definitely am looking for what? Any trauma, right. What else? Right, anything, even rashes. And I'm going to give you down and dirty on a rash. Dermatologist taught me this years ago at UVA, and that's the only thing I really know about rashes because I really don't like them. I'll start to scratch, especially if I've heard lice or bed bugs. But if you push your finger on part of that rash and it blanches, in other words, it gets pale, 2 thumbs up. Whatever's going on is not really a systemic issue. But if you push on it, it stays the same color, or red, or deep red, or ruddy, that's probably not a good reason. That means there's a capillary break and there's something causing that. So my anal sphincter gets a little tight when I see things that don't blanch really well. So again, if you push on it, this is a down and dirty way of looking at it and determine whether I'm going to be doing really fast or I can slow down my roll. But APCU is going to be good. Now what if the child has an ineffective or no pulse? What's your alphabet? CAB. And I always write D and E in here somewhere because obviously that's going to be diminished. But if I'm improving this, hopefully they get ROS, this will get better. But high quality compressions for no pulse or ineffective pulse in children. It's going to be your your best bet. And also knowing that you have high quality CPR going. And that means palpating a central pulse, somebody's doing that for you and saying, hey, I got good pulses with your CPR. And when I ventilate, what am I looking for? Chest rise and fall. Not crazy chest rise and fall, just enough volume to raise that chest and listen to the pits. Other things you're going to be talking about today are your H's and T's. Again, more alphabet soup. Everybody knows what your H's and T's are, correct? So if not, you have a resource in front of you. Some of those H's are probably not going to apply today, or even sometimes in these pediatric populations. But some of the T's also may not apply. We don't get a lot of tamponades, i.e. or thrombus in children, which is nice. We don't have to do a STEMI protocol. But that being said, H's and T's are of most help, especially when I'm trying to figure out what it is. The other one I like to use, and I've sort of done it myself, is fog. When I take care of sick or injured children, I want to make sure I'm not in a fog. And when I'm looking at those sets of letters, I'm looking for fluid, F. Are they hydrated? And what's the end point of adequate hydration in infants and children? P. That's exactly right, another letter, P. They have to urinate. For infants, it's really quite simple. What's the diaper? Is it dry or is it wet? And for children, when's the last time they voided? Yeah, the caregiver is going to help you out, I hope. O is for oxygenation. What's the oxygenation status? So what are we looking at for that? Are they tachypnic? And what's their O2 sat and does it correlate? What's normal O2 sat on an infant or child with no previous significant medical history?
84 to 99.
That's Ross. That's Ross. Very good. But if you have a kid with no significant medical history, they should be 98, 99, 100. There's really no reason for them to be any lower than that unless there's something going on, whether it's a big A, B problem or it's a C issue. But in the absence of any chronic history, kids should be well oxygenated. But I want to make sure that it correlates. In other words, it matches, that number matches what the pulse is picking up on your pulse levels. The other one is the G. What does G stand for? Good job. Yeah, it does. But also means glucose. Why is that so important in infants specifically? Because infants can die in true hypoglycemia. Brain cells die without energy. They need a triad. All children and infants need a triad of FOG, of fluid, oxygen, and glucose to maintain life. And if we don't give them that, those cells die, they're not regenerated. So in infants, just remember the smaller the package is, the limited reserves of glucose they have. So if you're going to start an IV, what can we draw really quickly and put your assistant can do for you? A glucose. I need to have a sugar. And when they give it to me during the beginnings of our assessment, and when I hear the number, I know if I have wiggle room or not. Right? So what's the normal blood sugar for an infant or child? What's that?
145.
It is. Infants can even go as low as 45, or newborns, really specifically newborn data. But from 1 month to up and up, it should be 60 to 99. Okay? It should be above 60. Just remember above 60, unless it's a newborn. And the reason is that when I hear that blood glucose, and the kid is not doing well, and somebody says to me, hey, Leanne, the blood sugar was 62 on the AccuCheck, what should that tell you critically thinking this through? Do I have a lot of reserve? No, I'm at 62. I don't have a lot of reserve. So that means if I hydrate this kid with 20 per kilo of normal saline, because that's what I'm taught to do, what's going to happen to that sugar? It's going to dilute it down. So I need you all to make sure critical thinking skills or CAPS are on, because some people in the hospital forget about critical thinking skills. And they don't realize that if you keep pumping them full of 20 per kilo until they pee, we're diluting things that are there. They may not have the mechanism to get that sugar and free it up. Especially infants, because they're not quite mature. So remember, that blood glucose is going to be of good use and get you out of the fog. So anything else that we utilize in assessing children, it truly is alphabet soup. I can put more letters up there that we utilize, either AHA does or doesn't. But again, it really comes down to what's going to be the best way to assess a kid and ongoingly reassess a kid. The other things that they've done too in the video, they talked about things like resus of fluid versus and vasopressors. Just, I'm not quite sure what vasopressor you guys have on board. Do you have dopamine?
Yes.
That's your best bet. And that's the one I would stick with. You can make an epi drip in the field. You can put epi in 500 or 1,000 cc's fluid. But dopamine is one of my favorite things to use because I can do a little can make it do a lot in a kid. So what they're saying for that one, and we'll talk about shock later, is just if after 60 per kilo this kid is not urinating or improving from a circulatory status, then make sure that you know that you might need a pressor to augment that. But also know this, that you need to reassess your kid every bolus, and two of the places you really need to assess is your breast sounds and hitting the pits. Because kids are going to start third spacing fluid, especially infants, they're going to start to lower. Always here first. Remember, it rise at ascends. So hit those pits. So any questions so far on that? I do have some handouts. I don't know if Kelly wants to give them to you later, but this is what we use at home, at the hospital. This is done dirty. We did this. Kim and I did this. She did it for ACL last time. We did it for PALS. And this is basically all the algorithms that PALS has. So it goes over all the pulseless rhythms, goes with the pulse and treatment modalities. Then it goes over the respiratory components of 4 and 4 of the shock. So sort of like a nice little cheat sheet, and it's pretty in color, at least the front is. And now you can take notes on it, but you can use this all day today, even in your Megaco. And there's some things here too. These are my tips. I put this out years ago, and I always update them every 5 years like AHA does. But it's just sort of some down and dirty things as to keep in mind when it takes care of kids. That's why I love PALS. Not a lot has changed, because children are very simple in our approach. If we can nail down it's an airway, breathing, or circulation problem, we can fix all 3 of them. And they're viable, because they don't have a lot of comorbidities sitting back there that we can't get them back, right? So any questions on those? All right, I think what we're going to do now is